GI examination. I begin by washing my hands, obtaining consent from the patient to perform the exam. For the general inspection, the patient does not appear in acute distress. There is no profuse sweating or paleness of the skin that could be indicative of pancreatitis. If the patient is writhing in bed, it could be indicative of a biliary colic. If in fetal position, it could be indicative of peritonitis or perforation. If a patient appears cachectic, think of malignancy. Looking at the chest, there's no red spots or reddish extension like spider nevi suggestive of chronic liver disease. If there's any signs of gynecomastia, it could be from liver cirrhosis. Inspect the mouth, and if there is any musty, sweetish odor, it could indicate fetor hepaticus from liver failure. Any angular fissures of the corner of the mouth or glossitis, think of iron or B12 deficiency. Look for any signs of central or peripheral cyanosis that could be indicative of secondary causes of hypoxemia. Looking at the conjunctiva, look for any pallor or yellowish discoloration of the sclera that could be indicative of anemia or jaundice like icterus. Looking at the hands, look for any signs of clubbing. Looking at the lobby-bone angle, if it's more than 180 degrees, think of cirrhosis, IBD, or amyloidosis. Look for any pulmonary edema indicative of liver disease. Look for any Dupuytren's contractures, which is thickening of the palmar fascia that could be indicative of alcohol abuse. Look for any spooning of the nails, like in koiloniki, indicative of chronic iron deficiency. Any whitening of the nails from leukoniki, indicative of hypoalbuminemia. Look at the arms. Look for any bruising or petechia from abnormal coagulation due to liver failure, like thrombocytopenia. Look for any resting tremor from alcohol withdrawal or any flapping tremor asterixis, indicative of hepatic encephalopathy due to ammonia retention. Also look for any track marks that could be indicative of suggestive IV drug use. Looking at the legs, look for any signs of pitting edema by pressing over the shin for 5 seconds. If it is present, think of a portal hypertension of right-sided heart failure. Abdominal examination. Patient should be in supine position, hands by the side and legs uncrossed. Bend down so the abdomen is at eye level. Should be flat, scaphoid, and symmetrical. If not, think of hernia and large organ or masses. Ask patient to cough. If protrusion increases in size, think of a hernia. If it is because of a mass, the size of the bulge does not change. If abdomen is distended, think of gas, fat, fluid, or feces accumulation. Look for scars. Note their location, size. Purple stripe could be indicative of Cushing syndrome. Look for Colling sign, which is ecchymosis periumbilically, or Great Turner sign, which is ecchymosis in the flank that could be indicative of retroperitoneal hemorrhage. Look for peristaltic waves over several minutes. If it is observed, think of intestinal obstruction. Look for engorged paraumbilical veins radiating from the umbilicus. If present, think of caput medusa due to portal hypertension or IVC obstruction. Make sure you know how to differentiate between these two. Auscultation. Warm your stethoscope to avoid spasms. Place the diaphragm of the stethoscope in the right lower quadrant and move to the right upper, and left lower quadrant order. Listen to the bowel sounds. Note their character and frequency. Normal bowel sounds consist of clicks and gurgles occurring every 5 to 10 seconds or 5 to 34 bowel sounds per minute. Borborygmi or stomach growling are long and loud gargles of hyperperistalsis from increased intestinal motility. Bowel sounds are increased in diarrhea and acute intestinal obstructions. If no bowel sounds are heard after 2 minutes, it could be indicative of paralytic ileus. Bruit auscultation. Bruits are vascular sounds or whooshing murmurs. Auscultate for bruits with the diaphragm. Auscultate over the aorta by moving 2 inches from the umbilicus. Normally, these sounds are heard only during systole, but if they're heard over systole and diastole, it is abnormal and it could indicate an abdominal aortic aneurysm or partial arterial obstruction. Now move 2 centimeters laterally from the aorta site. Listen over the right renal artery for bruits present in systole and diastole that could be indicative of renal artery stenosis. Make sure to also listen for bruits over the left renal artery by repeating the same process. Now place the diaphragm below and lateral to the umbilicus on each side to auscultate for bruits over the right and left iliac arteries. Now place the diaphragm below the inguinal ligament and about midway between the pubic symphysis and the anterior superior iliac spine to auscultate for the right and left femoral artery. Once again, bruits heard over systole and diastole are abnormal and could indicate partial arterial occlusion or aneurysms. Peritoneal friction rubs and venous hum. To evaluate for friction rubs, these are leathery grating quality sounds due to inflammation of the organ. Ask the patient to breathe in and out through the mouth. Auscultate over the right upper quadrant, and if it is present, it's called hepatic friction rub. It could be due to liver biopsy, perihepatitis from gonococcal or chlamydial infections, and if it is accompanied by a bruit, think of liver malignancy. Now listen over the left upper quadrant or spleen area. If sounds are present, it is called a splenic friction rub. Think of a splenic infarction. Now listen for a venous hum near the umbilical area. It is a humming or roaring-like sound due to increased collateral circulation between the portal and systemic circulation, as seen in those patients with portal hypertension. Evaluate for succussion splash. Use one hand to place down a stethoscope and hold abdomen in position. Use the other hand to shake the patient up and down. A slushing or distorting sound indicates distension of a stomach or colon, usually from gas or fluid retained proximal to the obstructed organ, as seen in colonic or gastric outlet obstruction. Percussion. Percuss each quadrant, starting at the right lower quadrant and move clockwise. Right lower quadrant should be tympanic due to the intestines are filled with air. The right upper quadrant should be dull due to the liver. The left upper quadrant should be tympanic due to the stomach. The left lower quadrant should be tympanic, or it could be dull, which could indicate feces. Keep percussing towards the umbilicus and go up through the aorta. Normally, there should be predominance of tympany. Flank dullness could indicate ascites. Any areas of localized dullness could raise suspicion for masses. Also evaluate for situs inversus, in which the organs are not placed in their usual location. Palpation. Begin with light palpation. Have the patient place the arms by the sides and bend the knees. Have the patient breathe in and out through the mouth as you palpate. Expiration helps relax the abdominal muscles. Make sure your hands are warm. Slowly and lightly palpate with one hand using the surface of your finger pads in circular motions over all the 4 quadrants in a clockwise order. Talk to the patient while doing this. It will help distract them and keep the muscles relaxed. Look for areas of superficial tenderness by looking at the patient grimaces. If localized tenderness, it could be appendicitis or cholecystitis, and confirm by having the patient cough and ask them if it hurts. If the patient localized the pain with coughing, try to map out the boundaries, and tenderness with one finger. Feel for muscular resistance. If it is present, distinguish from voluntary and involuntary rigidity. Voluntary decreases with relaxing of the abdominal muscle, while involuntary persists, and it can be seen in peritonitis. It is a board-like rigidity and it is diffuse. Now perform the deep palpation. Use both hands. Place the right hand on the abdomen and the left hand on top of the right. Palpate with the right and use the left to exert pressure. Try to identify deep masses like neoplasms over the right upper quadrant, abdominal aortic aneurysms over the epigastrium, diverticulitis over the left lower quadrant, or a distended bladder over the pubis. Note their location, size, shape, consistency, tenderness, whether they're pulsatile, and their mobility. Now evaluate for rebound tenderness. Over the area of suspicion, for example at the right lower quadrant, gently press slowly and firmly and quickly release. Pain is more upon release of the hand due to it causes rapid movement of the inflamed peritoneum. Now evaluate for rebound tenderness. If the area of suspicion is on the right lower quadrant, press on the left lower quadrant with the same technique. And if pain is felt on the right lower quadrant upon quick release of the hand, it is seen in acute appendicitis. If pain is felt on the right lower quadrant while you are applying the initial pressure but before the quick release of the hand, it is called Robson sign. Evaluate for obturator sign. Rotate the patient's right leg at the hip with the flexed knee. If inflamed appendix is in the pelvic position, pain occurs at the right lower quadrant due to irritation of the obturator internus muscle. This indicates a positive obturator sign. Psoas sign. Ask the patient to lift the right leg on extension while you exert resistance over the thigh. If inflamed appendix is in the retrostecal position, it produces right lower quadrant pain. This is due to irritation up to the psoas muscle from the inflammation, and upon stretching, the pain localizes. This indicates a positive psoas sign. A special test, liver percussion. Percuss along the mid-clavicular line on the right side. Start around the nipple level and move downward, covering all spaces until resonant node becomes dull, which indicates the upper border of the liver. Mark that border. Now, start from the level of the umbilicus and move upward until the tympanic node becomes dull. This indicates the lower border of the liver. Also mark that border. A normal distance between those 2 points should be 6 to 12 centimeters at the right clavicular midline, or 4 to 8 centimeters at the mid-sternal line. If the distance is increased, it could be signs of hepatomegaly. If the distance is decreased, it could happen because of free air present in the abdomen below the diaphragm, as is seen in ruptured stomach from ulcers. Also, gas in the colon may falsely decrease the liver size. Liver palpation. Ask the patient to flex the knees. Place your left hand on their back and lift. Place your right hand under the costal margin with fingers pointing towards the right shoulder. Ask the patient to take a deep breath in and feel for the liver edge with the tip of your fingers. Keep on lifting their back to help you feel. Now, feel for the anterior surface of the liver. Liver should be normally palpable. Percussion of the spleen. Start at the jugular notch, slide down 5 centimeters to the sternal angle, and move left laterally to locate the second rib. Start percussing at the second intercostal space. Keep percussing at each intercostal space until the 6th rib. This marks the superior border of the Trobbs space, which is demarcated superiorly by the 6th rib, inferiorly by the left costal margin, and laterally by the left anterior axillary line. Percuss at the Trobbs space with the patient breathing normally. There should be a tympanic note due to the stomach. Then have the patient take a deep breath and percuss again. Tympany should remain. If the note becomes dull on deep inspiration, it indicates a positive splenic percussion sign suggestive of splenomegaly, spleen palpation. Ask the patient to bend the knees. Support and lift up the left lower rib cage with the left hand while patient is supine. Ask the patient to take a deep breath. Palpate in a circular motion upwards towards the spleen with the right hand, starting at the right lower quadrant and moving diagonally to the left costal margin. Usually the spleen is not palpable. However, if it is, note tenderness and assess the contour. If it is enlarged, it's usually palpable 2 centimeters below the left costal margin on deep inspiration. Kidney palpation. Ask the patient to bend the knees. Place the left hand on the back just below the right 12 rib. Lift upwards. Ask the patient to take a deep breath. Palpate deeply with the right hand in the right upper quadrant just below the costal margin. Try to capture the kidney between both hands. Ask the patient to breathe out and stop. The kidney might be felt to slip from the hands during exhalation. Note the size, the contour, and tenderness of the palpable kidney. It might be abnormal in conditions such as hydronephrosis or polycystic kidney disease. The right kidney is normally palpable in thin-built individuals. Examination of the aorta. Press down deeply slightly left of the midline above the umbilicus with one hand on each side of the aorta. Identify the aortic pulsation, which is usually felt on most individuals. A well-defined pulsatile mass that is greater than 3 centimeters across is highly suggestive of aortic aneurysm, which is mainly due to atherosclerosis. Percussion for ascites. To assess, start percussing from the umbilicus outwards and note when the tympanic note changes to dullness. Mark those points where it changes from tympany to dullness. Usually in ascites, the dull note should start coming closer towards the midline, indicating fluid accumulation. Make sure to cover all around the abdomen and note the points of transition. Now evaluate for shifting dullness. Have the patient turn on the lateral left position and start percussing from the center outwards. Because of gravity, fluid will move down and the tympany that was initially central should move upward. Also, at this point, note where it changes from tympany to dullness and mark those points. Fluid wave test. With the patient laying supine, ask the patient to place the ulnar edge of their hand firmly along the midline of the abdomen. This helps dampen the transmission of any impulses through the fat tissue, ensuring that the wave detected is due to fluid. Place your left hand on one side of the patient's abdomen. With your right hand, tap or flick the opposite side of the abdomen. If ascites is present, you will feel a distinct impulse or wave against your stationary hand on the opposite side of the abdomen. A positive fluid test suggests moderate to large ascites. Now evaluate the kidneys for costovertebral angle tenderness. Ask the patient to sit on the side of the bed with his back facing you. Locate the 12 rib and place your left hand at the costovertebral angle. With your right hand, strike gently with the ulnar surface of the fist. Pain with CVA tenderness is suggestive of pyelonephritis. Evaluation of the Virchow's nodes. Have the patient sit on the bed and have the patient look up. Palpate over the supraclavicular area on the left side and note if there is any lymph nodes present. If they're present, note their size, their shape, their location, consistency, tenderness, and mobility. If they're present, it could be indicative of gastric or pancreatic carcinoma. Repeat on the right side. This should conclude the examination. Make sure to thank the patient for their cooperation during the exam.